Hello everyone, I'm Dr. Sakshi and today we'll be discussing about approach to a patient of azotemia. So what is azotemia? Azotemia is abnormal kidney function test. So if the patient has abnormal kidney function test, then we have to do two more tests. One is the urine analysis and the other is the renal ultrasound. In renal ultrasound, we have to look for any obstruction like hydronephrosis. So if it is present, then we have to remove this obstruction so as to improve the renal function test. Now if there is no obstruction, then we have to look for the renal size, the kidney size, and also the CMD. So if the kidney sizes, they are small in size, and also the altered CMD is present, then the patient has CKD. Now we have to see whether the patient has early CKD or late CKD or advanced CKD, because the management would be different. In early CKD, the patient has to be given symptomatic treatment and we have to delay the progression of the disease. Now if the patient has advanced kidney disease, in that case the patient has to be planned for the dialysis. Now the patient, if the renal ultrasound shows normal kidney size, then we have to look the alternate cause. We have to look the urine analysis, looking for various casts, and depending on the cast, we make the diagnosis. For example, if the urine analysis shows bacteria in it, then we have to rule out pyelonephritis. If the patient has WBC cast and eosinophils, then we have to rule out interstitial nephritis. Now there are presence of the RBC cast, then proteinuria, then it is glomerular nephritis or vasculitis, which could be immune mediated. Then the presence of RBCs, that means the patient has either renal artery or renal venous thrombosis. Then after this, if the patient's urine analysis is normal, it is not showing anything, but the patient is oliguric, then we have to do the functional excretion of the sodium, that is FeNA. FeNA is if it is less than 1% and urine osmolarity is greater than 500 milliosmol, then the etiology is pre-renal azotemia. So we have to hydrate the patient in this case. What are the causes of pre-renal azotemia? It is volume loss due to ME, like cardiac failure, sepsis, renal vasoconstriction, certain drugs. Now if the patient shows some muddy brown cast and also the FeNA is greater than 1% with urine osmolarity less than 350 milliosmol, then the diagnosis could be acute tubular necrosis. So this is the simplest method, the approach to a patient of azotemia. So whenever a patient comes with abnormal kidney function test, we have to approach the patient like this. We have to do urine analysis and we have to do renal ultrasound.